Hello, my name is Raul Clavijo. I'm an attending urologist at UC Davis Medical Center. You can reach me at the email address below and also at my office's phone number, 916-734-2222. Today we're going to be discussing testosterone deficiency syndrome. Begin by discussing how common this condition is. Many studies have been done on this subject, and I present one example of a study done in the Boston area. Essentially, these men were surveyed for both having low testosterone on the lab and also having low testosterone symptoms. As you can see here, the rate at which patients were diagnosed with this condition overall trended up as the patient got older. Of course, studies like the one just mentioned tend to vary in results, mostly because the definition of testosterone deficiency syndrome varies among practitioners and professional societies. Most do agree that a minimum of 2 testosterone levels needs to be checked, preferably in the morning. Along with this laboratory value, we do have to assess for symptoms somehow with a questionnaire such as the one shown here. A typical consensus value is having a testosterone of less than 300 to diagnose testosterone deficiency syndrome. Before going more into this subject, it's important to know how the production of testosterone is controlled by your body. In your brain, you have a structure called the hypothalamus, which produces a hormone called gonadotropin-releasing hormone. This hormone stimulates your anterior pituitary gland to produce another hormone called luteinizing hormone. It is that hormone, otherwise known as LH, that goes down to your testicle and stimulates your Leydig cells into producing testosterone. As you can see in this image, testosterone can be converted into estradiol, otherwise known as estrogen, through an enzyme called aromatase. Along with testosterone, most practitioners will order labs such as the ones listed. This will help us determine whether a patient's low testosterone is due to not enough gas from the pituitary gland, that is, low luteinizing hormone signal, or that the testicle is just not responding to the signal appropriately. Both conditions can also coexist. Along with these labs, it is important to realize that there are many serious medical reasons as to why a man's testosterone would be low, and studies for these conditions, such as hemochromatosis, may be needed in some situations. Common reasons for what is termed primary hypogonadism or testicular failure are listed on this slide. Common reasons for what is termed secondary hypogonadism are also listed here. In these conditions, it is an issue with the pituitary gland or hypothalamus not producing enough stimulating hormones for the testicle. Before discussing treatment options, it is necessary to go over the risks of testosterone replacement. A lot of attention to this came after the publication of a paper in the journal JAMA. This paper looked at men who had their blood vessels in their hearts looked at with a procedure called angiography, meaning there was a concern they had blockages. It essentially tried to answer the question as to whether the men in the group using testosterone tended to have a higher occurrence of strokes, heart attacks, or death. It is important to note that this was not what is called a randomized control study. In fact, the authors used statistical models to try to make up in the differences between the patients that were using testosterone compared to those that weren't. Another way of putting it is that they assigned scores to all of the conditions listed on the slide to even out the patients in terms of medical conditions. As you can see, there are many medical conditions that were attempted to be adjusted for. One can see here the actual rate of patients having things like a stroke or a heart attack was actually less in the testosterone group when you look at the raw data. After statistical modeling, however, the difference is essentially reversed. In my opinion, there are many faults to this article, and it's unfortunate that so much attention was given to it by the media. And on the other side, in terms of studies on testosterone, there are some, like this one, that highlight the possible benefits of testosterone replacement. As you can see from this graph, guys with low testosterone tended to die more quickly. Of course, this may only indicate that men with low testosterone have other medical conditions that are contributing to both low testosterone and death, and it may not have anything to do with the impact of testosterone on mortality. In this slide, I list the risks I tend to go over in clinic. One of the biggest risks is something called erythrocytosis, where your blood gets too thick. Theoretically, this may predispose you to stroke, heart attacks, and blood clots. Elevated estrogen is also a risk of testosterone replacement, and it can lead to symptoms of bloating, mood changes, and theoretically also blood clots. In terms of prostate cancer, it is likely safe after the treatment of low and intermediate risk prostate cancer, and there is no evidence that it promotes the formation of prostate cancer compared to the average man. Furthermore, there is no evidence that it will worsen your urinary symptoms or benign prostate hypertrophy symptoms. In terms of obstructive sleep apnea, there are some studies that indicate that it worsens obstructive sleep apnea, but there are others that don't. One of the bigger risks of testosterone replacement, and it's more important in younger men, is that the testicles tend to get smaller. And then the biggest risk is no improvement in symptoms. It's not surprising that there have been many studies trying to tease out the benefits of testosterone replacement. If you review most of these studies, you will find that sex drive or libido tends to be the symptom that reliably improves. Things like vitality, energy, erections, etc. tend to be less predictable, unfortunately, and we cannot predict who will have improvement in these areas. Finally, let's talk about how to best treat patients with testosterone deficiency syndrome. There are many options indeed, as you can see from this slide. Oral tablets are not available in the United States as they have been associated with liver injury. Injections of testosterone and anthate or cypionate tends to be a popular form of testosterone replacement. The benefits include easy absorption, a relative ease of self-administration, and most importantly for many patients, a low cost. The downsides include that you tend to get peaks and valleys of testosterone when you're injecting. This tends to become a little more blunted the longer you use it. Due to the peaks and valleys, you can have a fluctuation in mood or libido, and it tends to be associated with a stronger erythrocytosis, meaning your blood can get thicker more easily. Biggest issue with transdermal patches is that you can develop skin reactions at the application site, and compliance can be an issue too, as a lot of patients will forget to apply this patch. Similarly, transdermal gels can also cause issues with skin reactions and compliance. The other issue is a potential risk of transference of the testosterone to a partner or to a child. The name brands tend to be quite expensive, and I find that a lot of my patients have trouble with absorbing the gel to attain a therapeutic level. Intranasal formulations of testosterone are currently in the market and are undergoing clinical trials. They tend to be expensive, up to $125 per month. The benefit of them may be that it may preserve your pituitary function, meaning using this form of testosterone, you may be able to preserve your production of FSH and LH from your pituitary gland. Pellet implants is also a very popular form of testosterone replacement. The biggest risks of this are infection and the expulsion. In this slide, you can see what the testosterone levels may look like for patients on injections versus gels. As you can see, the gels tend to deliver a steady dose while injections have peaks and valleys. Unfortunately, price and poor absorption limit its use in many patients. The slide here shows how the administration of a testosterone pellet, otherwise known as Testapil, is done. The patient is lying down, and I use numbing medication to numb up the fat and the skin in his upper buttock. I make a small 5mm incision, and through this incision I introduce what's called a trocar that allows me to introduce several testosterone pellets into the patient. The benefit of this form of testosterone replacement is that a patient does not need to do anything for the upcoming 3 to 4 months, as he will absorb the testosterone pellets slowly over that time. The levels attained through this mode of testosterone replacement are also adequate and tend to get into the therapeutic range. Now finally, to monitor patients and ensure they are getting proper levels of testosterone, I do check their testosterone along with estrogen levels and a blood count. Overall, we don't want the blood to get too thick or the estrogen to get too high, as this may lead to blood clots. If these values are abnormally high, we do have several ways of managing them. Another type of patient I see often in clinic is the young male, meaning anywhere from 20 to 40 years of age, or even a little older, who is still thinking about having kids. It is important to know that testosterone replacement through injections, gels, or testosterone pellets, or any form of testosterone that is not your own, tends to lead to infertility, meaning it tends to drop your sperm count, and in most patients it can drop it down to 0 over 6 months. In terms of testosterone replacement in young men, there are a few options that can preserve their sperm count. One of them is HCG, otherwise known as human chorionic gonadotropin. This basically acts like a luteinizing hormone produced by your pituitary gland, and it basically goes down to your testicle and it stimulates it to produce more testosterone. And it's testosterone produced by your own testicle. The downside of HCG is that it requires 2 injections a week typically, and it can also be expensive, running at around $100 to $150 a month. Also, if your testosterone gets too high with HCG, you can inhibit the production of a hormone called FSH, which can theoretically decrease your sperm count. However, it should not eradicate it completely. Another option is a medication called clomiphene citrate, or Clomid. This is typically used in women to stimulate ovulation. It basically acts on your pituitary gland, and it stimulates it to produce more FSH and LH. These hormones go down to your testicle, and LH stimulates your testicle into making more testosterone. Clomid has been studied in young men, but there is no long-term follow-up information on this type of treatment option. The same goes for human chorionic gonadotropin, or HCG. The benefit of the good parts of Clomid are that it can increase your testosterone to therapeutic levels, and it is very inexpensive. The downsides are that it is associated with some side effects, including bloating and mood changes, as well as others. Now, in a patient who has an elevated estrogen level and low testosterone levels, we can use a medication called anastrozole in these patients. This medication is typically used for breast cancer patients, but since it decreases the formation of estrogen from testosterone, in patients with elevated estrogen levels, we can conceivably shift the balance of estrogen into testosterone using this medication. Thank you very much. My name is Raul Clavijo. I'm an attending at UC Davis Urology. You can reach me at the email address below, and you can call for appointments at 916-734-2222.